Okay, so this is week 12, upper extremity week 12, phalangeal and metacarpal fractures, and fractures at the knuckles of the hand and the digits, the metacarpals. Put into anatomy, talk about splinting principles, boxer fractures, the big kind of diagnosis for the week, phalangeal fractures, skier's thumb, which I think you're a little bit familiar with, mallet finger, and jersey finger. So these are the objectives. What are the splinting principles that apply to metacarpal fractures and phalangeal, proximal phalangeal fractures? How do you treat a digit fracture? How do you treat a mallet finger? And what is that? And how do you treat a jersey finger? And what is that post-surgery? Flexor tendon injury, jersey finger. And how do you, this is probably the most complicated thing we'll get at today, how do you test and stretch, kind of treat intrinsic and extrinsic hand tightness? Okay, so our dilemma for today, Clark Kent, 28-year-old male, walks into the clinic with a boxer's fracture. That means he's fractured 4th and 5th metacarpal of his hand, up by the pinky. It's non-displaced, did not require surgery, and is considered stable. He reports that it happened on a date with Lois Lane, and she dared him to punch out a wall. Apparently did not know that Lex Luthor had secretly put kryptonite in his underwear. So the question is, what orthosis would you make? What is your treatment plan? What are some complications that may occur? Okay, so let's go to the anatomy. Here's the metacarpals. These are all the metacarpals. This is the middle metacarpal here. Again, these are kind of the bones that are kind of, they're kind of buried in the palm. You don't really see them, like you see the digits. And then we have these phalangeals, phalange. There's the proximal one, the middle one, and the distal phalange. There's like 3 of them for the digits, and just the 2, obviously, for the thumb. Another good anatomy thing to point out, we'll talk about, is these little tufts, these little kind of, they look almost like mushrooms on the tips of the fingers. Those are called tufts, and those can get fractured as well. And then the intrinsics of the hand. Intrinsic muscles, as you know, we have the lumbricals, which do a lot of the flexing of the hand, and we're playing a role with extension. The IPs, and the dorsal interossae, who play a role between abducting, and the palmar interossae, who have a role with adducting, pulling the fingers together. Here's the extrinsic. These are basically the EDCs, the extensors on the back of the hand. Extensor digitorum communis, EI extensor indices goes to that pointer finger, and extensor digiti minimi goes out to the pinky. Fracture terms. Okay, I'm going to go over this. We talked about it last week. Non-displaced, they're kind of right aligned. No reduction is required. Clark Kent, when he punched the wall, his is non-displaced. There's no reduction either. There's pretty clean fracture. Displaced, they've moved out of anatomical position, needs to be realigned or reduced. This is done either surgically, they call it an open reduction, the ORIF, or with manipulation. They kind of do it, manipulate it, close it, reduce it in the ER or whatever, and they stick a cast on it. Comminuted is kind of the multiple fracture lines, kind of the shatter in a lot of cases, can be displaced or non-displaced. Really difficult usually to heal, needs to be pinned usually and all that. Intra-articular, maybe the worst, kind of goes through the articular surfaces that kind of meet the 2 bones as they come together around a joint, just like in the cartilage and joint space, much more difficult to heal. Interventions, non-surgical and surgical, we've already talked about that. Okay, so the boxer's fracture. Let's say the 5th metacarpal, right there. Gets right to the pinky, kind of like your knuckle bone. That side of the hand seems to take a lot of the blow. When you hit something, you usually get this when you're hitting an inanimate object, somebody gets mad, they attempt to punch the wall doesn't give, unless they're Superman, and they fracture one of their metacarpals. Here it is, right here. You can see it's kind of displaced. It's kind of a nasty one. Definitely needs to be reduced in some way. Different kinds of treatments. Conventional, mobilizing the form, cast, at least 6 weeks. Surgical, they're going in and plating and pinning to kind of realign it. How do we splint a Boxer's fracture. That's kind of the key thing. How do we splint that? If you think about these splinting principles, a lot of times it's the splint coming out of the cast, or kind of depending on how it's going. So how do we splint a metacarpal fracture? So definitely some splinting principles for you. You may have had some of this back with Katie over the summer, not sure. So you need to immobilize the joint above and the joint below. So if it's a fracture here, we're talking the joint here to there, at least, that kind of cast or splint. Can't allow too much motion. This is really going to put too much force to the fracture line and hinder the healing. Kind of shift everything, the tendons, kind of like similar to snapping a bone. It can kind of lead to all kinds of bad things. So you need to stabilize the joint to allow the healing to occur. We also have to think about the adjacent digits, the adjacent metacarpals or phalangeal, especially if it's a metacarpal fracture, because if you look at your hand, if you kind of move one finger, or try to move one finger, so if you try to move your middle finger, the other fingers start to move with it. The reason for that, as you probably know, is there's that big flexor belly and extensor belly on each side of the hand, and they have all those little tendons going down. Think of the FDS, FDP, and then the EDCs on the back side. So the one muscle, kind of almost like a puppet, works all those strings, all those tendons. So it's very hard, bottom line, it's very hard to isolate a digit and not allow other digits to move. And if the other digits move, get some of that shearing kind of thing, can't heal, throws things off. So you want to splint, especially with the metacarpal and the proximal phalangeal, splint the adjacent digit or adjacent metacarpal. So you have to splint both. Even if it's just on that fifth metacarpal, you'd have to splint the fifth and the fourth phalangeal together to avoid the shearing that it's talking about. So here we go. This is kind of the thing we're talking about. This is more like a classic gutter splint. It's in that intrinsic plus position. Remember intrinsic plus from 300, one of those grasps I made you memorize. This is a real functional position for splinting. Very common, very popular position for splinting. Kind of talk about that, why that is in the next slide. But with this, you can see how it's immobilizing fourth and fifth digit, the adjacent metacarpal, and it's kind of going below and above at least here, down here, assuming the fracture was right here on that knuckle. So you're splitting it up to the joint above and the joint below. Why does it go all the way out? Why is it in this position? Why is it in this intrinsic plus position? The MPs, if you have to immobilize them, we don't want them to get stiff and contracted. They seem to recover because of the physiology of the joint. They seem to recover better in terms of regaining motion once it comes out of the splint, if they're in slight flexion, like they are here. And the IPs, conversely, seem to like extension. You get less stiff if they're in extension for extended periods. This is also a little more functional in terms of recovering a functional grasp. Think of the alternative. If you kind of splint them like in a karate chop, with everything straight out, they may be stiff in that karate chop. It'll be harder to get that full or functional grasp so they can do the things that you need to be able to do. So that's why it's put into a little bit of flexion there, in addition to the MPs liking that kind of position. So you'll see this splint a lot. This is a common position for a lot of splints. Intrinsic plus and these dorsal blocking splints that we're going to be making, they kind of put them into what they call the safety position, the MPs flexed, the IPs extended. Okay, now we're talking the proximal phalangeal fractures. So here's the metacarpals. Here's the digits coming out of the hand. This is the first part of the digit between the MCP and the PIP in there. So it kind of goes along like that. Looks displaced to me. Does not go through the surface as well. Looks displaced. Sports injuries, car crash injuries. Andrea, the CHT that helps teach this class, she says she gets a lot of these injuries around walking the dog. People wrap the leash around their hand, the dog smells something, sees a squirrel or something, quick jerk to the hand, and you get these little fractures. How do you treat that? This kind of splint, kind of a hand cast. See, it's again and towards a functional grasp. It's not fully extended. Again, we're getting the MPs flexed, the IPs extended here. That same principle. In the same principle, we're splinting across. Here we're getting multiple metacarpals involved and phalangeal, proximal phalange involved as well as up here. So you're getting that adjacent digit kind of thing, because you're going to get shearing the two lower parts of the digit. Really hard to isolate them and not prevent that kind of shearing motion where they kind of want to work together kind of thing. All right, so that's the proximal and the metacarpal fractures. Now we're kind of working our way further out the hand. This is the middle part of your hand, the middle phalanx fractures here. Here you don't have to worry so much about the shearing. Those kinds of principles are not so much. If you get a fracture kind of in, I'm going to figure this out, but like was in here, you're splinting from the joint below, the joint above. So it's a joint down here, the joint above, kind of thing. And we're kind of just splinting it into extension. So you don't want to lose that flexion in this case. This is about 6 weeks for it to fully heal. Same kind of principle. If we go further out, the DIP joint, the distal phalanx, those little tough fractures we talked about, those look like some nasty ones. Andrew talks about people breaking these when they use their finger to open containers, like say there's plastic and you're trying to pop the plastic to pull open a wrapping around a package or something. A lot of people, when they do that, they break their distal phalanx. She says she always uses scissors or something. Now she doesn't use her extended digit anymore. So with this, conventionally, we're just getting that gutter splint again, extending it out for like 6 weeks kind of thing. Here's the tough fracture, just kind of talked about, an image there. All right, so here's a question. This is a client that Andrew had, I think it's with the real x-ray, stuck his hand, got his hand jammed in a wood splitter. And he had some multiple fractures here. These are all the metacarpals. This is the second, third, and fourth metacarpal he fractured right there. And here's the phalangeal, proximal phalangeal with thumb that he fractured as well. So he had a fracture there and all the way across. So the question is, how would you splint that? From which joint to which joint? And then how many digits would you splint as well? Give you a second to kind of think about that, see if you can figure that one out. So from which joint to which joint? So this is the issue. You've got to go at least for the MCPs down to the carpals. And then across here, you're talking MCP up to the IP joint of the thumb. So you're talking about a pretty involved splint. And then which digits? Definitely all that's fracture digits. And then we want to get this guy as well, because that may be causing some shearing. So it's going to be a splint that's going to come all the way across the hand, probably in that intrinsic plus position, MPs flexed, IPs extended. Pretty involved splint. Here's the fracture treatment kind of protocol, progression. This should look familiar to you. It's pretty much the same exact thing as last week when we were talking about the wrist fractures. Again, it's a bone fracture, kind of a universality to it in terms of the healing progression. Generally speaking, everybody's a little bit different. This is when you have to kind of see what's going on with the hand, communicate with the doc about orders and that sort of thing that we've talked about. But again, 4 to 6 weeks, you can start your gentle active range of motion a little bit earlier if it's pinned. Going after the edema. Again, that's enemy number one. All those different strategies for an edema we talked about. Retrograde, patting the kitty. Excuse me. The armpit, all that sort of stuff. Tendon glides, get it moving. Gentle active range of motion within tolerance. 5 to 6 weeks, you can start gentle, passive moving, range of motion, waiting from the brace. They 7 weeks, they're completely off the brace, getting into light EDL. In about 8 to 12 weeks, it's healed, they're good to go. You're really going after it aggressively with stretching and strengthening. As with the wrist fractures, a lot of times there's complications they have to be kind of familiar with the hand, with these digit and metacarpal fractures. Probably the biggest one is tightness. Tightness, usually it's in the palm of the hand. The intrinsics, kind of pulling it into flexion to kind of losing that extension. Sometimes it's on that back side of the hand as well. So we're calling what the extrinsic and intrinsic. We talked about the intrinsics are those deep kind of lumbricals in the palm of the hand, do a lot of the flexing of the hand, the MCPs. Extrinsics, we're going to focus on the EDCs on the back side of the hand. Obviously, they do a lot of the extension. So sometimes the flexors, the intrinsics get tight, or the extensors of the backhand, the extrinsics get tight. So we have to figure out, okay, so this hand is not progressing, these digit fractures are not progressing the way I thought they were, they're not keeping up with the protocol. What's the deal here? Is it intrinsic or extrinsic tightness? That's kind of usually your number one culprit. So you kind of tease that out. Which one is it? How do you know which one it is? And how do you treat that? You kind of assess how it is, which is it, intrinsic or extrinsic tightness, through something called the Bonnell or Bonnell-Littler test. So the Bonnell-Littler test is probably the most confusing test that we have to do. I think the key with this one is not to overthink it. You start thinking about this too much, you're just going to make your head spin, you're going to start going in circles. Try to keep it as simple as you can. So try to keep it as simple as we can. So with the intrinsic tightness, we're trying to see, is it intrinsic tightness that is the issue with the digit? Usually what you're focusing on with that is the PIP joint. So let's think of the PIP joint of the pointer finger. All right, so I'm just going to go here. Sorry. So we're testing for intrinsic tightness, focusing on that PIP of the finger. We can kind of do this together. You can't see my finger. If I have my MCP extended, so that means the finger is going straight out, sticking your pointer finger straight out, and I bend my PIP, coming down, trying to get full flexion of that PIP coming down. Let's say I can't get it all the way down. It goes about halfway, and it gets really, really tight. So with my MCP extended, my PIP, I cannot get full flexion. It goes about halfway. And then I flex my MCP, make a fist sort of thing, bend the finger down to about 90 degrees, and then I flex my PIP, I can go all the way. This is telling us that this person has intrinsic tightness of the hand. What is this doing? We go back to what I just did. So if you extend the MCP, sticking your finger straight out, here we're putting the intrinsics, they're stretched to the limit. The intrinsics are being stretched to the limit, and this MCP is extended and your finger straight out. So with those intrinsics stretched, I should be able to bring that PIP all the way down. If I can't, it's telling me that there's tightness in the palm of the hand, intrinsics. Conversely, if I flex the MCP and then do the same thing and it goes all the way down, it's telling me I'm getting really good glide, really good motion on the back side of the hand. That's not an issue. The extrinsic on the back side of the hand, the outside of the hand is fine, but the intrinsic, since I can't flex that PIP with the MCP extended, is tight. So that tells me, with this Bonnell-Littler test, that I have tight intrinsics in that first or that second digit. Extrinsic tightness is basically just the opposite. So we go back to what we did. So we extend the MCP, we extend the digit so it's straight up, and this time we try to flex the PIP, and it comes all the way down. We have full flexion with the MCP extended. We have full flexion. And then we flex the MP, and we try it again. So now we've flexed the MCP to 90 degrees. We're trying to flex the PIP again, and this time I can get full flexion. This is telling me, I'm sorry, I can't get full flexion. It only comes down a little ways. So again, with the extrinsic tightness, MCP extended, PIP comes down all the way, full flexion. But when I flex the MCP and try to flex the PIP again, I can't. So it goes about halfway. This is telling me there's tightness on the back side of the hand, the extrinsics. there is a video on this. I try to find some simple ones. I would check them out in the treatment box. Try to keep doing this until you get it down. We'll keep going over this repeatedly. So how do you treat this? So let's say we have extrinsic tightness. So that basically is, we're talking in this kind of simplified version, tightness on the back side of the hand. Usually it's the EDCs, the extension determinant communis, that are tight through there. How can you stretch those? Just kind of think about it. Making a fist, flexing your wrist, extend your elbow. You just do that. Make a fist, flex your wrist, extend your elbow, and really push your wrist down in deflection. Can you feel the tightness? The stretch on the back side of your hand? You're stretching the extrinsics. It's a good stretch for that. Conversely, the intrinsics. This is usually the culprit, tightness in the intrinsics. How do we stretch that? Pretty much how we did the Vanilla Littler test. Just put it more into hyperextension. We just kind of crank on it. That's pretty much the same thing. So what we do is we extend the finger, we extend the MCP joint so that finger is sticking straight out, and we even put it into hyperextension. So we're pushing it back into hyperextension, and then we're going to push it down, that PIP into flexion. Kind of what we're doing here. See how he's pushing it back into hyperextension. Now he's cranking on that PIP and pushing it down. That's how you stretch the intrinsics of the hand for that particular finger. You can also heat it up. You can do some joint mobs, might loosen up of that joint. Static progressing arthrosis, kind of pushing it down further and further, that sort of thing. Other complications, something called extensor lag. This kind of plays into its extrinsic tightness a little bit. A lot of times the person cannot get full extension anymore. Usually, a lot of times the culprit is scarring, adhesions along the pulley lines with the tendon slide through the pulleys. You get little scars and all that forming from being in the cast and the trauma of this, the fracture and all that. A good kind of simple way of going at that. You can stretch it like we talked about, making the fist and flexing your wrist. We also can do some scar mobilizing, do some Dyson. So go in the opposite direction of the pull of the tendon. So if you just play around with your hand, keep flexing it and extending it. So the opposite direction pulls as we extend it, the tendon goes back, doesn't it? Just feel that tendon. It's coming when you flex your hand. So you're flexing and extending your MCPs, your knuckles. As you flex the hand, try to make a fist, the tendon is going forward. As you extend it, coming backwards. And we want that extension. That's where it's being hindered. So it's coming, the tendon is gliding backwards as we come back. So you're going to go the opposite with your Dyson. You're going to be pushing forward. So you're going to be going proximal to distal with the Dyson. We'll do this in the lab when you get a chance. Got to see it to kind of get it. It's a hard one to kind of visualize. We also have something called sympathy pain, like the finger next to it. Start to get sore. Try to do some range of motion. Try to isolate the digits. Just holding the fingers back so they don't all go together, kind of thing. That might help with that. Buddy taping might help with that as well. Kind of what it says. You're taping the two fingers together. So let's say this guy is where the fracture was. You're getting some sympathy pain. This guy's getting sore, trying to keep up with everything that's going on. Tape them together. They start working together, helping each other out, give each other a break. That may help reduce the swelling and all that causes the pain. So buddy taping may be effective as well. It's another option to think about. Okay, some other soft tissue injuries and avulsion injuries. Avulsion is like when your tendon and the bone get pulled right off together. I'll show an image of that in a second. Skier's thumb, gatekeeper's thumb, mallet finger, and then jersey finger. Whoops. Here's the skier's thumb. They call it skier's thumb because a lot of times, kind of a good visualization of it, you're skiing, you fall, and your abducted thumb lands on the ski pole, pulls it back, and it tears or rips this joint in here, this collateral ligament. It's connecting the MCP with the metacarpal, the MCT joint right in here. That's where the rupture usually is. It's the omocollateral ligament that is the issue. It's torn or frayed, that kind of thing. Extreme force. Here's some good images of the UCL, the omocollateral ligament. See, it's on both sides of the bone. So here's the metacarpal. The phalanx is usually right in here where it gets strained, or in this case, ripped right off, torn right in half. And treat that with a splint. This thumb spica splint that kind of goes all the way across, gets the metacarpals in there as well. Got to be in there for at least 6 to 8 weeks for that to heal. Use the same kind of splint for something called gamekeeper's thumb. This might be more difficult to get rid of, more of a chronic kind of thing. Attrition, wear and tear. It's kind of chronic instability in the joint. It's called by attrition, repeated strain over time. Not a single acute injury, but you could try treating it with the same kind of splint. See if that calms it down. Mallet finger. What is mallet finger? It's jamming the tips of your finger, basically. Sometimes called basketball finger or even baseball finger. Visualize you're playing basketball comes at you, and you don't grab it with an open hand, you grab it with your fingers kind of like in a flexed, your DIP is in a flexed position, and it jams with your DIP flexed. And what it does is it ruptures the end of the extensor tendon, because it's jamming so acutely that tendon running over the top of the hand, that EDC running on the top of the hand gets torn, and sometimes it's like an avulsion in the bone. The tendon kind of pulls right off. Here's an image of it. Here's like football, DIP flexed, wax it, and see this piece of the bone. That's what when I call it an avulsion tear. It rips a piece of the bone off along with the tendon. Nasty kind of thing. It kind of looks like this. Looks like a swan neck. So acute injury can cause a swan neck. Can also cause a boutonniere. That just gets too confusing. Like a mallet finger can look like this post kind of injury. That DIP, PIP hyperextension, DIP flexion. That's usually the issue. And what you need to do is splint tendon extension. Usually like for 6 to 8 weeks. Can go longer. It can be challenging to fully heal that tendon. Maybe some pinning might need there, a surgical anchor to kind of reconnect it. Either one of these kinds of splints are okay. It's good to have actually a combination of these little splints. Give the skin a breakdown, because they have to kind of wear this around the clock. They have to be really religious about wearing this to get it to heal. Jersey finger. Jersey finger is kind of the opposite. So the DIP is not flexed, but extended. And they kind of call it jersey finger. If you visualize somebody reaching for a jersey, say like in a game, football game, it's kind of a rough, acute rip or hyperextension as they're grabbing that jersey. And what happens is the flexors, which as you know the profundus runs underneath, the volar side of the hand, the palm side of the hand, ruptures. It's a tendon injury, which is a forceful extension and ruptures that tendon. And what happens, the person knows that tendon has been ruptured because they cannot flex the tip of their finger anymore. See, this guy's trying to make a fist. He can't get the tip of his finger to flex, to make that full normal fist kind of there. He may have a flexion tendon tear. They treat this, and here it is, another good image of it. See how it's kind of torn here. This really should be like a hyperextension kind of thing. It's deceptive, but this is the tear right there. How do you treat that? They do surgery on that. It's like considered a flexor tendon injury. So you do that flexor tendon protocol. We're going to get right into that next week. This is kind of a lead into our next lecture after Thanksgiving. And you do this dorsal blocking splint. You're going to make these splints. And you have to follow the strict protocol. I won't get into that, but it has to have surgery. It has to follow the flexor tendon kind of protocol. Okay, so going back to our case, kind of splint orthosis would you make? He has that classic boxer's fracture. He fractured his 4th and 5th. I would give him that intrinsic plus splint that we looked at. So it's kind of splinted with his MCPs slightly flexed, IPs extended. It's going to involve the 4th, 5th, and probably the 3rd metacarpal, coming at least away across like that. coming up the forearm until we get at least get the MCPs, probably the PIPs, and down to the carpal bones, get the joint above and below, and the adjacent digit in this case. 6 to 8 weeks comes out of that. We can start doing the protocol, for a healing fracture that begins at 4 weeks with the active range of motion. Okay, what splinting principles apply to metacarpal and proximal phalangeal fractures? These, the two big principles are splinting above the joint above and below the fracture. That's number one. Number two, splinting the adjacent digit or the adjacent metacarpal. So if it's just on, say, the second digit, you need to splint it across to at least that second digit because of that shearing principle. How do you treat a digit fracture? Depends on where it is. Let's say it's a DIP or PIP fracture, the middle or distal. You can splint those into extension. How do you treat a mallet finger? Mallet finger, again, splinting it into extension 6 to 8 weeks. Jersey finger, how do you treat jersey finger post-surgery? You can put in that dorsal blocking splint, follow the flexor tendon protocol, which we'll get into next week. How do you test and stretch for intrinsic and extrinsic hand tightness? That's the Bernal-Littler test. I'll run through that one more time. Bernal-Littler. We're looking for intrinsic tightness, which is usually the culprit. I'll just do that one so I don't use it too much. So you extend the MCP, extend the fingers, so the fingers going straight out. You start flexing that PIP joint, tight. Can't come all the way down. So it goes halfway. And then you compare it to that when you flex the MCP, try to make a fist kind of thing. Let's say you can go all the way in now. So it's a lot more motion with the MCP flexed than when extended. That will tell you that you have intrinsic tightness. You start doing intrinsic stretches, which are basically forcing that PIP into flexion with the MCP extended. Okay, after break, we have a quiz. Come back after break. The lecture is going to be on the flexor tendon injuries. It'll be me and Dustin Blackington, a really skilled hand therapist. He's going to be up in Portland talking to you folks and doing the splinting stuff. And keep working on the AOE, which is do 12-7, hand construction do 12-7. Just to kind of review the AOE again, which you guys started in the lab. Some tips around that, areas where people kind of forget or they kind of lose points. Don't forget psychosocial interventions. He has mental health issues. Think of some ideas. I'm looking for him anywhere. It could be on those questions, or it could be in your big treatment box. Need some kind of psychosocial interventions around his mental health issues. Activities. Don't just with the exercise. Don't just do exercises. Exercises are great. You can pull out that stuff from the treatment boxes, which I saw a lot of you doing. But also don't forget activities that he likes to do. I'm not talking about activities that simulate his job, not a work conditioning kind of thing. I'm talking about just using activities that he likes to do as part of his hand therapy. Don't forget to adapt what he does, what he likes to do, especially when he's working. Can you adapt things to make it easier on his wrist, his fingers? Addressing all potential complications. There's 2 potential complications it kind of hints at with that hand, with that wrist fracture. I was looking for you to address both of them. Make sure there's uniformity in your group paper. I would love to divide and conquer and get it done as fast as you can. But when you're submitting this individually to your grade individually, make sure all the parts look good. If one part is not getting these things we're talking about, definitely want to kind of fix that. You can just resubmit it if you want to redo it. Okay, so that is all for week